Welcome to The Language of Evidence. Today I'm going to offer some reflections on Retsef Levi that I called The Double Life of Retsef Levi. An independent thinker joins the advisory committee on immunization practices. According to my unofficial count, Senator Ron Johnson of Wisconsin holds a modern Senate record. 5 roundtable discussions in the last 5 years. The closest second is 2. What are these roundtable discussions? They are held in the historic Kennedy Caucus Room in the Senate office building, are open to the public, and are broadcast live. And given his controversial views, he, for example, suggested mouthwash as an effective COVID-19 intervention and was accused by CNN of spreading other misinformation during COVID. I've covered him in my prior episodes, in the first episode in particular. You can imagine that these roundtable events showcase the who is who of the anti-establishment world. So at the November 2nd, 2021 event, about a year and a half into COVID, there were several patients who gave testimony, often very emotional, describing complications they suffered after receiving COVID-19 vaccines that Ron Johnson and others described as vaccine injuries. There was Aaron Seary, the lawyer for Informed Consent Action Network. He gave a presentation talking about his law firm with a staff of 20, and of course now he said it's up to 40. And as he was speaking in that panel, he was at the time a lawyer for ICANN, an anti-vax nonprofit started by Del Bigtree, and that goes back to 2016 when he and Andrew Wakefield made their first documentary, Vaxxed. So you can imagine the people at that meeting. So Retsef Levi made an unlikely presence at that meeting. A professor of operations research at MIT. His 2 most recent research papers, just for context, one is called Competitive Algorithms for the Online Minimum Peak Appointment Scheduling and Improving Farmers' Income on Online Agri-Platforms, Evidence from the Field. And note the pun in the second one, from the field. Farmers. So what was a mathematician and a professor of operations research doing at a vaccine injury roundtable? And how, 4 years later, did he end up on the advisory committee on immunization practices? And what about the comments he made and the questions he asked at the last ACIP meeting? Were they reasonable? And why did he vote against recommending an RSV antibody, clesrovimab, made by Merck? And this antibody is not even a vaccine. It's given once to an infant and lasts for several months, covering the entire RSV season, which is about 5 months. And this antibody reduces the rate of infant hospitalization due to RSV by 84% and was approved by the FDA just prior to this ACIP meeting. To me, this is a story about conspiracy beliefs. Half of Americans have such beliefs, perhaps you and me included. But equally, this is a story with implications of our new U.S. healthcare leadership for the future of ACIP, the future of clinical research, and the practice of medicine as well. Levi declined to be interviewed for this story, citing limited ability to interact with media. He did, however, give several recent interviews. I'm not offended. Those interviews were to conservative outlets. One was to Epoch Times, which is described by the New York Times as conspiracy-fueled outlet. Levi also gave 2 interviews to Marianne DeMasi, who works for Brownstone Institute. The Brownstone Institute, incidentally, was started and is led by Jeffrey Tucker, the mastermind behind the Great Barrington Declaration, and such an extreme libertarian that he encouraged his teenage kids to smoke. I actually had a chance to speak to him a couple of months ago, and I hope to talk about that conversation in a future episode. So looking at Levi's recent interviews and older archival material, you get a picture of his double life. One as an MIT professor and one not obvious at all from his MIT website, as a critic of the COVID response and a conservative darling. There was the Senator Johnson hearing in 2021 that I started with. He also participated in the March 2022 gathering of the Academy of Science and Freedom, which is an anti-lockdown group founded by Scott Atlas, Martin Kulldorff, and Jay Bhattacharya, which was held at the ultra-conservative Hillsdale College in Washington, D.C. And this gathering is where Levi met Tracy Beth Hogue. And in fact, that's how we know that he was there, because she mentioned this at the podcast she ran. And she's now, of course, a top advisor to Marty Makary, and previously papers with him, one of which was considered misleading by factcheck.org. And she's also good friends with Jeffrey Tucker and Joseph Ladapo, Florida's Surgeon General appointed by DeSantis. In 2023, Hogue hosted Levi as a guest on the podcast she runs, along with Christine Benn, a vaccine expert often quoted by Kennedy, who has done work on the DTP vaccine in Africa. And Levi himself said this about Ladapo: A+ on intellect and moral compass to do the right thing, what public health needs. And since mid-2024, Levi, under a misspelled name, has been on the editorial board of Science, Public Health Policy and the Law, the anti-vax journal that published, with Andrew Wakefield's help, the famous Mawson paper that helped Kennedy pass his confirmation hearings. But Levi doesn't list this editorial position along with a few others that he has on his MIT CV. And by the way, the reason I know this is an anti-vax journal is that it's described that way by one of the editorial board members, who told me that they openly consider themselves home for anti-vax papers that are not accepted in other places. So it's incredible to see the circles, the conservative anti-establishment circles that Levi is connected to and is part of. So I wanted to find that moment when his second life started, and I pieced together his bio. He was born in an industrial Israeli town of Kfar Saba, one of 8 siblings, and his father was a journalist and a veteran of the Stern Gang, which is an extremist Zionist organization. And as a Israeli journalist described Levi in Haaretz, a leading Israeli newspaper, Levi seems to have inherited his parents' penchant for challenging their surroundings. He served in the Israeli Defense Forces as an intelligence officer, what he describes as special forces, for 12 years, well more than the mandatory 2.5 years for Israeli men. And his subsequent career path seemingly had nothing to do with healthcare. He studied math at Tel Aviv University, PhD in operations research from Cornell. His PhD thesis is called Approximation Algorithms for Stochastic Inventory Control Models. Nothing health-related there, I checked. However, once he joined them in 2006, he started a collaboration with Mass General Hospital to improve the scheduling of surgical patients, which ultimately grew out into a new department at MGH, Healthcare Systems Engineering, that still exists today. By 2016, he was leading MIT's Sloan School of Management Initiative for Health Systems Innovation, HSI. And that's when the first slight note of sort of discontent appears. Concerns with the status quo. He said, the current health system is designed to provide discrete, reactive care for sick patients in specified locations. The idea of health is going to be broader, more comprehensive. What do patients eat? Do they smoke? Where do they live? It's going to require us to think deeply about what we do for every patient and how we think about the welfare of the population. But the turning point for Levi was COVID. When COVID started, he immersed himself in pandemic response. He joined MIT's COVID-19 Policy Alliance, was interviewed by the Washington Post about the risk of hospital collapse, his area of expertise, and helped multiple other researchers. There are multiple papers around the beginning of COVID where he is acknowledged as an advisor. He also embarked on his first COVID-19 related research project together with the trainee Christopher Sun, a Canadian postdoctoral fellow, with a dual appointment at Levi's MIT School of Management and the MGH Healthcare Systems Engineering Department that I mentioned. And Sun notably had significant prior healthcare operations experience. And that's when Levi's frustration with the U.S. response is becoming apparent. He said in an interview early in the pandemic, we definitely did not perform very well as a country compared to other countries. But actually one of those other countries also did not perform well, according to Levi, and that was Israel. In mid-2020, at the invitation of Israel's education minister, Yoav Gallant, Levi spent 6 weeks on a team of experts planning for safe reopening of Israeli schools. In that same Haaretz correspondent, Arlos Sorov, described Levi as mad over what he sees as the unnecessary closure of the education system. He quotes him as describing the government decision-making process as unprofessional, not transparent, based on the belief that the only effective response to the pandemic is a strict lockdown with no effort made to pinpoint high infection areas and crack down only in those places, she quoted Levi as saying. He made some proposals for optimizing healthcare response as well, reducing personal protective equipment for healthcare workers. He thought it was excessive. Bringing in retired doctors and shortening the quarantine period. So Arlazorov says, Levi's proposals aren't necessarily right, but he isn't alone in his criticism. And she continued, their criticism resonates because their claims aren't considered at length and because it's clear that what is being done has failed, she observed very astutely. And mid-2020 is also when Levi and Son embarked on their second COVID-related project that appeared to be the pivotal point in Levi's career bifurcation and likely earned him the invitation to Ron Johnson's 2021 gathering. It all started with the news of myocarditis as a complication of COVID-19, and to a lesser extent of the vaccines. Levi recalls that he was reading about myocarditis and how much of it can go undiagnosed. If there was an increase of undiagnosed myocarditis in Israel after the COVID vaccine rollout, how would we know? He asked himself. And he came up with a very interesting approach to analyze ambulance calls during the third COVID wave in Israel. That was when vaccines were rolled out. And he thought that he would compare ambulance calls during that time to the prior waves when vaccines were not yet available. So COVID was there, but the vaccines were not. And any difference would be solely due to the vaccine reason. Of course, at that point, variants were not commonly discussed, so that was not part of the consideration, although now we know that every COVID wave was different because of the different composition of the variants. This paper was ultimately published in April 22, and it's remarkable in that it is really all about one curve, the number of ambulance calls per week. These are the calls that people make. In Israel, it's not 911, it's 101. So these are the calls that people make to that emergency number. And he tracked those calls for about a 2-year period. And in his paper, there's a graph that has this red line zigzagging up and down across the page like a mountain range. On a slow week, there were 4 calls. There are not a lot of calls because he's specifically looking at calls among young people because those are the people who were impacted mostly by myocarditis and only for heart-related issues. And it's not common for young people to have heart issues or to call an ambulance. And so there are very few. So on 1 week, there were 4. On a busy week, 9 or 10. And there are a few peaks in this curve that get close to 9 or 10. And there was one that had 11. And that happened to coincide with the main COVID-19 vaccine rollout in Israel. And when I was looking at that curve, I was asking myself, looking at that red peak that extends above the 10 line, and I was asking myself, does it look that different from all other peaks? And to me, it clearly does not. So whatever happened at the same time as that peak, maybe it was an earthquake. Maybe it was some stars aligning. Maybe somebody said a prayer. We really cannot conclude that this little peak was caused or even associated with that other event, because there were several other ups and downs in this curve. It just, for all intents and purposes, looks to me like noise. Plus, the difference from week to week is just a few calls because the numbers are so small. So if on a given week somebody made 1 or 2 extra calls, then perhaps there could be another week that would have made it to the top. And so we'll come back to this a little bit later when we're talking about sort of a conspiracy mindset, but you can see how seeing more than just noise here could be described as illusory perceptions of pattern and causality. So we'll come back to this a little bit later. But Son and Levi came to a different conclusion. They do very complicated math that I am not able to comment on, and they try to show that this peak's timing was not a coincidence. They do acknowledge that they didn't know who these patients were. The data that they collected on ambulance calls did not include this information. And they didn't know whether these patients were actually vaccinated and what their final diagnosis was. They know that the call was originally for a heart-related issue like chest pain, but what ultimately the doctors found them to have was not captured. And what was a bit surprising to me is that they don't even describe what we call the demographics of the patients. So their average age, percent males versus females. That is usually what clinical researchers will call table 1. And that is literally the table 1 in every paper like this. Whenever you're describing a group of people, clinical trial, observational study, etc., you always start with table 1 that tells us about this group. But in this case, what is that group? So the title of the paper talks about an under 40 population in Israel. So is that our study population? Then we might want to know, what was the total under 40 population of Israel when the study was done? How many were there? What was their average age? Okay, so we know they're under 40. So their average age was 20, half below 20, half above 20. Maybe it was skewed towards a little bit lower, 15, a little bit higher, 25, I don't know. What is their men to women ratio? It should be probably about 50-50, but we don't know. The paper doesn't say. And by the way, did this population remain the same over the course of the study from 2020 to 21? Exactly the same or approximately the same? So maybe that is not our study population. Then what is? Well, there's a section in the paper called Data Sources and Study Population. But this section doesn't say anything about the study population, actually, even though that's what the title says. It describes 2 data sets. One is the data set of emergency calls, all the calls received through Israel's National Emergency Telephone Number, 101. And the other data set is vaccination and COVID cases. Data on the vaccinations and COVID cases were obtained from the online Israel government database portal. Okay. So then what is the study population? Is it the calls plus the vaccinations plus the cases, the COVID cases? Well, we cannot link them because they're not linked. We don't know who the calls were from. There is no study population in this study, and that's why there's no table 1. And so why is this important? Well, because first of all, it's in the title of the paper, the under 40 population, but also this is very important for interpreting the results of the papers. We had 8 calls one week. We had 10 calls another week. Out of how many people total? How many people under 40? In fact, they look at the population 16 to 40. And we may want to think about what are their typical ailments. When a 16 to 40-year-old person calls 911 or 101 thinking that something is wrong with their heart, what are the typical reasons? Maybe usually when someone 16 to 40 calls with chest pain, maybe it's myocarditis, or maybe usually it's a pulled muscle. It's hard to know if we don't know what the population is. And to answer that question, we need to know more about this population. For example, there was one study in 15 to 33-year-olds seeking emergency care for chest pain in the UK. That's kind of similar to 16 to 40. And it turns out that in that study, over half of ultimate reasons were not related to the heart. There was a pulled muscle or something gastrointestinal or respiratory, but it's hard to know whether it applies to Levi's study. Does Israel have more men than women, or vice versa? Where do they live? Maybe the emergency call came from the north of Israel and the COVID cases were more in the south. I don't know. With this basic problem, no table 1, I can confidently say, and I hope you will agree, this is not a quality study. And there's more. There's some math, what I might call sleight of hand, that is evident. If you look carefully, the points on the graph do not correspond to whole numbers. Like the lowest point is almost at 4, but not quite. And the peak that we talked about is almost at 11, but not quite. It looks almost like 10.5. Oh, how is that possible if it's the number of calls? How can you have 10.5 calls? Well, it turns out these are not actual numbers of calls each week, but a 5-week moving average. So taking a window of 2.5 weeks before, 2.5 weeks after, calculating an average for the 5 weeks, and then putting that average number on the graph. So why did they do that? Why did they do the moving average? And why did they pick 5 weeks as opposed to 3, 4, 6? They don't explain. And similarly, they present a sea of numbers in a table, comparing 2019 to 2020 to 2021, whole year versus January to May, total population under 40, over 40, males under 40, females under 40, etc., etc. And they calculate a percent increase from before the pandemic to the pandemic to the pandemic with vaccines. What was the increase in calls, the percent increase? and the p-value, whether this is something that could be due to chance. And then pick out those that look high. Females under 40, specifically for acute coronary syndrome, there you see about a 35% increase from the pre-vaccination level. Again, a 35% increase could be from 6 to 8 calls per week. So 2 extra calls per week in all of Israel. But that's in one category. Women under 40 for one cardiac reason. But if you look, for example, at males under 40, for another cardiac reason, cardiac arrest, there's no statistically significant increase. So this is what some scientists call a fishing expedition. And that is a statistical no-no. Why? Because the more you slice and dice the data, the more things you will find. But most of it will be due to chance. So if you did the study all over again, you might see a different pattern. Maybe now it's the men under 40 and the women over 40. There is some noise because we're basing everything on just a few calls per week. And this was illustrated very nicely by a leading statistician, Thomas Fleming, whose name will be instantly recognized by clinical researchers as the developer of the O'Brien-Fleming boundary that is often used in clinical trials. And the way he explained this in his article called Clinical Trials, Discerning Hype from Substance, he told the story of how once he visited a hospital nursery. I think somebody in his family was giving birth, as I recall. And he noticed that there were 20 newborn boys and only 2 newborn girls at that particular point in that nursery. And so being a statistician, he calculated a p-value to see how likely this could have occurred by chance, given that generally you would expect equal numbers of boys and girls. And the p-value came out to 0.0001. Very, very unlikely due to chance. In other words, if he set out from the beginning to find a nursery that had such a big difference, he would have to visit thousands, maybe like 10,000 nurseries to find one where he would see this imbalance. So only once one would expect to observe such an imbalance. Yet it's clear that Fleming had not visited so many nurseries. This, in fact, was probably his first visit to a nursery. How is that possible that on his first visit he stumbled upon such a rare event? Well, the explanation for this paradox is that he did not go into the nursery with the plan to study the ratio of boys and girls. This was just one of many observations he made. Maybe he saw 3 red cars in a row along the way to the hospital. Or maybe he ran into 3 people with the same name, or 5 people with the same. These sorts of random coincidences happen very, very often. So his summary is that the interest in being able to interpret and report results in clinical trials as being favorable is pervasive throughout healthcare research, he cautions. In exploratory analyses, p-values will be misleading when the actual sampling context is not presented to allow for proper interpretation. He talks about this random high bias. If you're walking around, if you're observing these coincidences, and as soon as you see one, you're like, aha, there it is. Let me make a conclusion from this, that red cars like to be parked together. No, it's just chance. And of course, we already talked about the fact that 2 extra calls a week. 2 calls. 2 people somewhere in Israel picking up the phone and calling 911. We don't know who those 2 people were they vaccinated or not. We don't know what the doctors found at the end. Maybe it was nothing. So this entire paper is based on ups and downs of very, very small numbers. 1 or 2 calls here and there across all of Israel, a country of 6 million people. So many limitations of the study, but only one, the lack of follow-up, is acknowledged by the authors. And they're so convinced that these findings were real that even when they're faced with strange observations, like, for example, they see more cardiac events in females while COVID myocarditis is more common in males, they attempt to rationalize these observations rather than admitting that it's likely a chance finding. So they said, this may suggest the potential underdiagnosis or under-self-reporting of myocarditis in females. And at the end, Sun and Levi conclude, while not establishing causal relationships, the findings raise concerns regarding vaccine-induced undetected severe cardiovascular side effects and underscore the already established causal relationship between vaccines and myocarditis, a frequent cause of unexpected cardiac arrest in young individuals. Really? Given the massive limitations of the study, to me, it does not raise concerns. And What is the basis for mentioning severe cardiovascular side effects? We don't actually know the diagnosis these patients received and what proportion was cardiovascular. We don't even know whether these patients received the vaccine. And how did myocarditis get into the concluding sentence? So if I describe this as connecting the dots that are not connected, that's what I see in this paper. More on this later. So if I were in the Israeli Ministry of Health or at the FDA and I got this paper, I would not find it actionable. So I wouldn't be sure what to do about it. But that's not how Levi saw the findings. At the Ron Johnson Roundtable, which was around the time that they were submitting this paper to journals, he is visibly tense. His neck veins are puffed up. I am not an anti-vaxxer, he says. I'm not a Republican. I'm not a Democrat. I'm just a scientist who challenged the current narrative that dominates public health policies around the world, in the US and in Israel. I know many scientists who, like me, think that the current narrative is very extreme and wrong, but very few of them are willing to speak up, and I am not sure I can blame them. Any attempt to deviate from the main narrative today is faced with a wall of hostility, rejection, and even elimination. He quoted a senior colleague at MIT who warned Levi, you have to be careful or you can be eliminated. Me and my co-authors pointed out that if you look at national emergency service calls in Israel, you see a dramatic 25% increase in these calls, in parallel to the vaccination campaign, he announced to the stunned room. We wrote a paper about that, not claiming that we have a causal effect, because we don't have a proof of that. But we did raise the concern, and we called the authorities to check what is going on. Needless to say, we never got a response from the authorities. First, this is not entirely consistent with his other descriptions of this story. In another video, he said that the FDA called him back right away. It was the Israeli Ministry of Health that never responded. But also, why needless to say? Is it like a foregone conclusion that the authorities do not care about safety? Or maybe there's another explanation. They just didn't consider the study to be reliable or actionable. And in fact, Levi continues in a way supporting his last explanation. In fact, they went public and called this research fake. But even more concerning, journal after journal after journal in the academic literature is rejecting this article. Most of the time based on the argument that he leaned into the microphone and looked at Senator Johnson. It is not a priority. Well, I don't think calling safety concerns fake is morally right or scientifically right. And by the way, 3 weeks after this event, Sana and Levi submitted the paper to Nature's Scientific Reports, the world's 6th most cited journal, and it was published a few months later. So it did get published. So here, for me, the logical leap is on display. He says, my paper was rejected by multiple journals. My concerns were not taken seriously by multiple regulatory agencies. And that's not because there was anything wrong with my paper, but because there is a coordinated effort between the journals and the agencies around the world to cover up the truth. That's how his logic goes. Once healthcare agencies decided to give this vaccine to all ages, including young people that are not high risk, they committed themselves to a path that they cannot admit to any wrong. Levi said on that podcast that I mentioned, Tracy Beth Hoag's podcast in 2020. And that's the reason why we see denial and efforts to suppress any efforts to understand what the risks are in spite of mounting signals. And by the way, just for the record, I'm not aware of any evidence that global health authorities were purposefully hiding safety signals for COVID-19 vaccines or any other product for that matter. Janssen's vaccine was restricted by the FDA after a safety signal emerged, and a few months before Levi's presentation at the Roundtable, EU regulators announced a positive link for the AstraZeneca vaccine, a positive link to very rare cases of unusual blood clots. They had absolutely no problems of coming out and announcing that. But if you listen to Hoag's podcast from 2023, this perspective was lacking. I think that it's so important, and podcasts like this are important too, to talk about our experience as researchers, Hoag concurred with Levi. And you can see Christine Ben, that I mentioned, the GTP researcher, she's nodding. And this is where I bring my intelligence hat, continued Levi. Before coming to academia, I spent 12 years in intelligence. Often we would say, this indication doesn't prove it, and this finding doesn't prove it. But you have to step back at some point and look at the mounting evidence and say, hey, something is wrong here. So why would a researcher compare his struggles to publish a paper? This happens all the time. To the work of a military intelligence officer piecing together clues about the enemy. And I think that's the thought that also crossed Tracy Beth Hoag's mind as the host of the podcast, because she jumped in and she said, well, it's important to know we're not conspiracy theorists. Okay. So what could she be referring to? What does that mean to be a conspiracy theorist? Well, I came across the work of Karen Douglas at the University of Kent in the UK, and she's one of the world's leading experts in conspiracy theories. And she says the most common feature of a conspiracy theory is that something is being covered up, she explained in an interview. And she talked about how she came to be interested in this area. She said, I have always been interested in the psychology of attitudes and attitude change. I have also studied how people's behavior is influenced by new communication technologies. A few years ago, I came across some conspiracy theories online while looking for study materials on another topic, and I became intrigued by them. So, interestingly, many of us believe at least one conspiracy theory. And there's a table in one of her papers, and ironically in the same journal where Levi's paper was published, that has various conspiracy theories that people believe. So, for example, the top 1% of the richest people in the US control the government and the economy for their own benefit. 52% of the people believe that. I actually believe that. So, I count myself. Do you think the government is keeping information from the public that shows that that UFOs are real or that aliens have visited the Earth? 50% of the people believe that. The dangers of genetically modified foods are being hidden from the public. 40%. The number of deaths related to the coronavirus has been exaggerated, and presumably a lot of deaths were caused by the vaccine rather than the virus itself. And look at this one. The FDA is deliberately preventing the public from getting natural cures for cancer and other diseases because of pressure from drug companies. 35%. Actually, very similar to elites from Hollywood and government are engaged in a massive child sex trafficking racket. 34% of Americans believe that. So how does this happen? And in 2022, Douglas published a paper called Rabbit Hole Syndrome. Inadvertent, accelerating, and entrenched commitment to conspiracy beliefs. And she describes, well, what is a rabbit hole? If you look at Alice in Wonderland, and she says it's actually a very apt analogy because you can be drawn into it incidentally and find it difficult to get out of. It then draws you ever deeper in a non-linear descent, basically going faster, faster, faster. That's like the term conspiracy theory itself. The rabbit hole metaphor is not necessarily pejorative. It's just something that happens to a lot of people. People do not enter the process intending or even expecting to develop a deep commitment to conspiracy theories. Their attention, like Alice's, may be captured by something interesting or appealing. Importantly, people appear unable to detect how exposure to conspiracy theories changes their beliefs, and so may not notice what is happening to them in these early stages of rabbit hole syndrome. Then comes acceleration, due to essentially a vicious cycle. As conspiracy beliefs increase, people increasingly identify with other believers, adopting identities such as truther or critical free thinker, that in turn encourage deeper commitment to these beliefs. Illusory perceptions of pattern and causality seem to play a role in conspiracy beliefs. As conspiracy theories become more salient in people's representations of the world, they can become the very stimuli between which people, smart or even academically brilliant people, are not immune, writes David Robson. He's the author of a book called The Intelligence Trap, Why Smart People Make Dumb Mistakes. In one study, he describes more educated participants seemed less likely to update their beliefs after they had been debunked. Instead, they actually become more certain they were right. Somehow their greater knowledge simply allows them to dismiss the new information and harden their attitudes. So going back to Levi, in March of this year, he posted on X a discussion of nirsevimab, a monoclonal antibody recommended by the CDC and in Israel against severe RSV. Clinical trials raise serious concerns, he said. 5 deaths in the treatment arm versus 0 in the placebo. Essentially the same rate of serious Respiratory infections. Does this sound like the reassuring level of safety and efficacy for a drug given to healthy young infants? Thanks to Efrat Shur for collaborating on the analysis in early March of this year. So there are three mysteries about this post. First, what prompted it? He references two New England Journal of Medicine articles, one from 2022 and one from 2023. Nirsevimab was approved in the US and Israel in 2023. There was no Nirsevimab news in 2024, 2025. Levi would not be appointed to the Advisory Committee on Immunization Practices, ACIP, until June 9th. And the agenda that included Nirsevimab would not be published until June 18th. So that's one mystery. The second mystery is Dr. Efrat Shur, whom Levi thanks for collaborating on the analysis at the end of this post. She is Levi's only co-author on two papers, one on COVID-19 vaccine safety during pregnancy and one on the risk of miscarriage after COVID-19 vaccination. These are both papers about pregnancy, not pediatrics, pregnancy. That is the domain of obstetrics, not pediatrics. Pediatricians do not take care of pregnant women. But Shur is on the other hand, is a pediatrician. And she's currently practicing in Jerusalem, Israel, with no apparent academic affiliation. And it's not clear that she has expertise in the research methodology on which her papers with Levi are based, judging by her three publications in addition to the two with Levi. As a matter of principle, I would expect an obstetrician, someone who takes care of pregnant women, to be an author on a paper discussing pregnancy. And why would a full professor at MIT co-author a paper with a pediatrician with no academic affiliation about obstetrics, a different area of medicine? This is a mystery I have not yet solved. And then the third mystery is whether Levi tried to find answers to the concerns he raised, perhaps by talking to experts before or after posting them on X. It does not appear that this happened. There's actually a mistake in this post when he's talking about the same rate of infections. And his point is that if this antibody is preventing infections, why is there the same rate of infection? But he's quoting the numbers from a different trial. So it's a mix-up. A simple mistake, but it's sitting on X since March and it has not been corrected. And it makes me wonder, if he actually talked to someone, they would have probably caught the mistake. A few months ago, The Lancet, a top medical journal, had a special issue devoted to RSV. And so I will just quickly go through that to give you some perspective on the dangers of RSV. And there's an accompanying video. It's about 10 minutes. I highly recommend it. And in this video, Dr. Ruth Caron of Johns Hopkins University presents a striking number. 33 million children getting sick and 100,000 children dying each year due to RSV around the globe. And this is actually the second most common cause of death in infants after malaria. And most of the deaths are in previously healthy kids. And there is still no treatment for RSV. But in 2023, Dr. Karen says, remarkable progress was achieved with the introduction of a vaccine for mothers and a long-acting antibody like Nirsevimab for the whole season. But they're only available in high and middle-income countries, not in low-income like Kenya. Why is this a problem? Well, there are two reasons. First, low-income countries have very few intensive care facilities, leading to high mortality. And this is there's another speaker in this video, Dr. Mazur, a Dutch pediatrician. So there was a Band-Aid solution that was proposed, high-flow nasal cannula, oxygen through a small tube at high pressure. But Dr. Mazur says that this was shown in latest trials to be not only ineffective, but even potentially harmful. So she says prevention is key. We are in an exciting new chapter now that RSV can be considered a vaccine-preventable disease, she says. But it highlights this enormous problem in low and middle-income countries that do not have prevention tools available, that getting RSV in one of these countries with no supportive care, not enough ventilators, is much more dangerous than in the US. And the second problem is long-term complications. And another doctor, Dr. Heather Zar, a professor of pediatrics at the University of Cape Town in South Africa, talks about complications of RSV infection. And she says that RSV infection in early life can lead to stiffer lungs, which can impact life expectancy long-term. And this is in kids who survive. We're talking about kids who survive their RSV infection. They either don't go to the hospital or they go to the hospital and go home. Everything is seemingly fine, but there's a certain number of them that will develop stiffer lungs. That may limit their life expectancy when they're adults. It may shorten their life. And so she's saying that the public health value of the prevention products is likely greater than what is measured by early life RSV disease. So we're not just preventing the children from the early problems with going to the hospital. We are potentially helping them live longer as adults. Now, I'm not sure whether Levi is familiar with any of this or talked to any of these researchers, but it appears that at the ACIP meeting on June 25th and 26th, now this is 3.5 months later, 3.5 months after his post, his concerns remained unresolved. And recall that in early June, Kennedy fired the entire ACIP and appointed several new members, including Levi. And at the ACIP meeting, nirsevimab was actually not on the agenda, but there was a supportive analysis of nirsevimab that was presented. But actually, the topic for the vote was on the newer, similar antibody called clisrovimab that binds to a different part of RSV. It was just approved for healthy infants by the FDA a couple of weeks earlier, and the question was whether ACIP essentially agrees with the FDA approval and is okay to add clisrovimab as an option to the schedule and to the vaccine for children program that would allow for reimbursement. And just to explain for a second the difference between FDA approval and ACIP recommendation, the FDA approval really only happens just once, whereas ACIP may review these products, vaccines, and rarely non-vaccine infectious disease products such as antibodies on a regular basis and may take into account changing rates of infectious disease, epidemics emerging, etc. And at the meeting, Dr. Adam McNeil, Deputy Branch Chief for Epidemiology at the Respiratory Viruses Branch at the CDC, went over a presentation of the risk-benefit analysis that he said was prepared by a working group including CDC and external experts. In the U.S., to this day, tens of thousands of children are hospitalized for RSV, and 80% of them are healthy. These infections carry the risk of long-term lung stiffness, as I mentioned, and other long-term complications. And a few hundred die from RSV acutely, according to Dr. McNeil. And we're not even talking about those who may potentially have their life cut short in their adulthood due to a stiff lung. So after reviewing the benefit and the harms of clisrovimab, Dr. McNeil presented the working group's recommendation, approve. And then there was time for discussion, actually on the following day. So Levi was the first to ask a question. I would like to share data that I found and would be happy to hear the reactions of the colleagues at the CDC, he said. He then proceeded to repeat his number one concern from his March 4th post on X. In the nirsevimab trial called MELODY, there are more deaths among children receiving nirsevimab compared to placebo. Isn't that concerning? He said. Well, it turns out, it took me a couple of hours to figure this out, and I'm not even in the government. But a quick look at the FDA review would have addressed that concern. The FDA review documents for every drug are posted on a portal called Drugs at FDA. So I immediately went there to look. And then in this document, under key safety issues, there's a section called Imbalance in Deaths During Clinical Trials. It says, there was an unexpected imbalance in the number of deaths observed in subjects who received nirsevimab compared to subjects who received controls. Therefore, deaths in all trials were carefully reviewed to determine if any death might be related to nirsevimab. And there's a nice summary of all the trials. There's a nice table, table 49, if anybody wants to take a look. So when you add everything up, there were 12 deaths out of 4,000 patients who received nirsevimab versus 4 of about 2,000 who received control. And why are there half the number of people who received control? Well, because very often in these trials, they do what's called 2-to-1 randomization, so that each child has double the chance to get the drug as opposed to the placebo. And that helps with enrollment. Studies can enroll faster that way. That doesn't mean that we know for sure that the drug is better than the placebo. It's still possible that the drug could be worse, but that's a common approach. So we had 12 out of 4,000 versus 4 out of 2,000. So if we had 4,000, so it would be 8. So basically it would be like 12 versus 8. Yes, It is an imbalance, but these numbers are very, very small. And I'm not a statistician, but I just went to ChatGPT and I said, what is the p-value for 12 out of 4,000 versus 4 out of 2,000? And it produced a page worth of formulas, and then it gave me the answer, 0.4. So remember, the p-value has to be as little as possible. It has to be less than 0.05. That would indicate that probably there's something going on. If it's more than 0.05, then the difference you're seeing is probably totally random. So if you go to one casino and you hit the jackpot 12 out of 4,000 times, and you go to another casino and you hit the jackpot 4 out of 2,000 times, do not pick the first casino. You, at this point, you have no idea which one is better. Total random chance. You could be making a big mistake by going to the first one. But to be sure, the FDA reviewed each of the deaths, 12 plus 4, each of the 16 deaths. And there's a 2-page table that outlines them. And by the way, the trial was done in multiple countries. So only one of the 16 deaths occurred in the US. One child in Panama was hit by a car. A child in Bulgaria was born infected with another virus, CMV, and was quite sick. A child in Mexico had severe heart defects at birth. A child in the US was born with a brain tumor. So reviewing these deaths, the FDA concluded, correctly in my opinion, that the imbalance of effectively 12 versus 8 deaths, given that so many of them are clearly not due to drug, that this was all due to random chance. Now, this document that I just described dates back to May 2022 and is easily available online. So why didn't Levi review it? It only took me a couple of minutes. Plus, he could have asked the FDA. He's in the government. He could have written to the FDA and said, hey guys, can you remind me what happened with that? Instead, he posted the concern on X in early March, and then he repeated that verbatim, that same question he posted on X 3.5 months later. Then his concern number 2 that he raised in the ACIP meeting, no surprise, also essentially exactly his concern number 2 from his X post. Why do you see the same rate of infections, including RSV, in treatment versus placebo arms if this drug is supposed to reduce RSV infections by 75%? Yes, why is that, I thought? That's strange. Is he on to something? Shouldn't we expect the rates of infections to drop? Well, this answer was also easy to find. Just a quick look at the trial protocol, which is part of the trial publication. It turns out that a bunch of smart people who designed this study 6 years ago, 19, thought about this issue very carefully. And here's what they came up with. In this study, the respiratory infections occurring up to 6 months post-dose of the antibody constitute the studied clinical outcome of interest. That is, they are efficacy. They basically indicate how well this drug works. And therefore, any hospitalizations due to RSV within the 6 months period will not be considered and reported as serious adverse events. So the answer to Levi's question is very simple. The RSV hospitalizations don't show up in the safety section. That's why you don't see the difference. In contrast, Levi, not knowing this simple explanation, constructed a more complicated and a more scary explanation that while the RSV infections are reduced by this drug, some other mysterious side effects are taking their place. And he was holding this concern to himself for 3.5 months just to raise it at the meeting. In fact, Dr. McNeil's presentation was on day 1 of the ACIP meeting. It ran late, so they postponed the Q&A until day 2. So Levi had to hold this question for 1 extra night to drop the bomb the next morning. He then turns to clesrovimab, which is the actual topic of discussion. And he says, if I look on the clinical trials of the product we're supposed to vote on today, clesrovimab, again, a trial of 2-to-1 randomization, there's again imbalance of 7 deaths to 3. Okay, let's pause here for a second. Here's a full professor at MIT. The trial is 2-to-1, meaning there are twice as many kids getting clesrovimab as placebo. So, and there are about twice as many deaths, 7 versus 3. I mean, exactly twice would be 3.5. So what did he expect? 3.5 deaths on the placebo arm? And, I could not believe what I heard, that an MIT mathematician considers this an imbalance. So I went back and heard again, and I took a screenshot. But that's exactly what he says. Okay, so that we can say that is just ridiculous. But then he drops an actual bomb, and he says, and it seems that there is an ongoing trial with clesrovimab in infants with comorbidities, 1-to-1 randomization. and it does report 8 to 4 deaths. I would like to hear from our colleagues at the CDC, should we be concerned? This question was passed on to Merck, who said that similarly to nirsevimab, all deaths were reviewed and deemed not associated with RSV or interventions. Okay. So I went to drugs.fda to find the glucosamine review document, but it was not there. So we do not have access to the table of deaths like we do for nirsevimab. I'm sure it's there. I'm sure the FDA looked at it just like they did for nirsevimab. But this raises a few questions. First, how did Levi find out about the 8 versus 4 deaths? First, I thought, is this confidential? Like, is he allowed to just reveal confidential information in a meeting? No, actually, it turns out it's very easy. It was part of Merck's presentation at the conference in October of last year and was presented at the last ACIP meeting in November. And both of these are available easily online. So the second question, does this change anything? Also an easy answer. Instead of dropping the bomb at the ACIP meeting, why not talk to the FDA who approved this drug 2 weeks prior? Surely they reviewed and deliberated this in detail. Third, what is the p-value? There were 900 patients in this trial, 1-to-1. So I asked ChatGPT, what is the p-value of 8 out of 450 versus 4 out of 450? The answer is 0.24, also due to random chance. Remember, p-value has to be less than 0.05. Okay, so what if we were to combine both drugs? And first of all, I should say, nirsevimab and glucosamine are different drugs. They bind to different parts of the virus. So we should not consider them together. But even if we did consider them together for a second, I did this math, 12 out of 4,000 versus I multiplied by 2, 8 of 4,000, 7 of 24, 6 of 2,400, 8 of 450, 4 of 450, adding everything up. And even though I cheated and combined different drugs and multiplied by 2, which inflated the p-value is still 0.18, still due to chance. And the reminder, for context, the efficacy. So we have some random imbalance of deaths, very, very few expected. Some of these infants are quite sick, even before they got RSV. But what does glucosamine actually do to RSV? Well, it reduced the main thing that they looked at in this trial, medically attended lower respiratory tract infections, by 60%. And then some other measures like total hospitalizations were even more, were reduced by 84%. So this drug clearly works. And we have no evidence that there's any pattern in the deaths beyond some noise. Okay, now the fourth question. Why was 8 versus 4 not part of McNeil's presentation? And perhaps the CDC decided to keep this out to avoid unnecessary questions and rabbit holes in the new ACIP. And that backfired. So lesson learned. Do not hide things. And fifth, I have a conspiracy theory of my own. Just like the 1%, the richest people. I have another conspiracy theory. Remember Aaron Seary, the lawyer for Del Bigtree's ICANN, who was sitting close to Levi in that November first roundtable? So let's say that they kept in touch. It's possible. Late January 2025, Seary's law firm sent a letter on behalf of ICANN to HHS that says, specifically, we encourage you to closely review the data that showed double the number of infant deaths among the treatment groups for both glucosamine studies. Again, they're making the same math there. Okay, the professor made it, so of course, they forgot that one of the trials was 2-to-1. So 7 versus 3 is actually very, very expected. It's not an imbalance. So a few weeks after this letter, Levi posts his concerns with nirsevimab on X. And then at ACIP, he calls 7 versus 3 an imbalance, repeating ICANN's math error. So is it an MIT professor not understanding how to multiply by 2? Or not wanting to disagree with ICANN? So that's my own conspiracy theory. Okay, now, finally, Levi made a concluding statement. And just for context, remember again, Lancet video, 33 million hospitalizations, over 100,000 deaths due to RSV globally. So I encourage you, with all of this in mind, to watch his concluding statement. If you search ACIP Day 2 on YouTube and go to 27 minutes, 57 seconds, there it is. I'm a scientist, but I'm also a father of 6 children. And I think it's also important to put yourself in the shoes of a parent. One of the things that makes me, beyond the science, the data, I was asking myself, if I was just a young parent of a baby, and I had the amazing opportunity to be in this situation 6 times, and I know all the information, how would I think about this dilemma? And I think if I had a baby that was born early and had, God forbid, some underlying conditions, knowing the threat that RSV can pose to a baby like that, I would probably use these products to protect my child from this disease, since it can cause death to the baby. On the other hand, if I was the father of a healthy child, knowing all of this, I would be concerned to use that. And I think I understand that we're trying to reduce the burden of hospitalizations, and these are all very important metrics. But I think we need to ask ourselves what a parent would say given these data. And I think most parents that have a healthy baby would be concerned to use a new product against a disease that turned out in the past to be quite tricky. I think they will be concerned. And I, as a father, can feel that I would be concerned. Okay, first, it's not clear what he means when he says these products, or I would be concerned to use that. Is he talking about both antibodies or just clisrovimab? Not clear. And second, the only imbalance is that is evident for clisrovimab is 8 versus 4 in trial number 2. And I didn't go into the details, but this trial number 2 is actually in children with comorbidities, in sick infants. So if he thinks this is a real difference, which we know it's due to chance, the logical thing would be not to use it in children with comorbidities, the opposite of what he proposed. And finally, I was talking to a colleague, an expert in vaccine hesitancy, and I mentioned I will try to interview Levi, and she said, please remind him that the whole world is watching, and see if you can explain this to him. He's a mathematician. And I said, I know. I will tell him multiply by 8 billion. What I would ask Levi is simple. Talk to experts before you make a statement. The whole world is watching. Ask questions before the televised meeting. Don't hold your questions with the mix-ups and all for months. And most importantly, assume positive intent. There is no conspiracy. There are simple explanations for most things. People are not trying to cover things up, just trying to do their job. So I will end by discussing the interview Levi gave along with Robert Malone to Epoch TV on Saturday. I heard that Kennedy was livid after the ACIP meeting. Perhaps too many yes votes. So this interview was perhaps an explanation to the boss. For those of you not familiar with Epoch Times, my mom used to love their news site. And when I learned this, I asked her to stop. And she said, why? I like it. I sent her this from from Media Bias. Further, the Epoch Times frequently publishes pseudoscience news, such as supernormal abilities. They also publish false claims from pseudoscience and anti-vaccination activist Joseph Mercola, who has a long track record of publishing misinformation. Finally, in addition to claims that alien abductions are real and the deep state engineered the drug epidemic, the channel pushes QAnon conspiracy theory, which falsely posits that the same Spygate cabal is a front for a global pedophile ring being taken down by Trump. So now you know what you're dealing with. Jan Yakilog is their senior editor and the producer of a 2023 documentary, The Unseen Crisis, Vaccine Stories You Were Never Told. The documentary features familiar characters, Senator Ron Johnson, and the leaders of a pro-ivermectin group that used to be called FLCCC, now renamed IMA, Pierre Corey, Robert Malone, Paul Marek, Peter McCullough, Warner Mendenthal. I was at a recent IMA conference where I met Yakilog. He moderated a panel. Epoch Times was the only media outlet that was allowed at that meeting. I know others tried, but were told no press. And Mendenthal and other lawyers were working the room looking for new clients. So in Saturday's interview, after PBS Frontline style cold open, and I can tell you this is no PBS Frontline, but you can decide for yourself which is more reliable. And then some opening remarks by Malone. Jakilek turned to Levi. Retsef, you were very, very important for me in terms of my understanding of all sorts of policy around the pandemic. So Levi was teaching Jan Jakilek about policy around the pandemic. So this reminds me of my grandmother's favorite Yiddish saying, Azoch und Weh. It's basically as och und weh, meaning like och and weh, which loosely translates as pity on him. And then Yaakov continues, through speaking with you quite a bit, I understood that I should look at everything from the concept of risk-benefit analysis, whether that's specific policies, whether that's products that are being used as interventions because of disease. So then Levi comments, in my mind, the ACIP role is to translate the generic approval by the FDA into a set of more detailed recommendations that take into consideration the risk-benefit aspects that could be different for different subgroups of patients. And there I would, not being an expert on ACIP, I would disagree. And I would propose that Levi's characterization is not exactly correct. And this is what the ACIP charter says. The committee may revise or withdraw their recommendations regarding a particular vaccine as new information on disease epidemiology, vaccine effectiveness or safety, economic considerations, or other data become available. So this is the important part. Following disease epidemiology, for example, We don't have a committee that meets 3 times a year to review cancer therapeutics, because cancer epidemiology doesn't change so quickly. So a cancer therapeutic gets approved by the FDA, and then it is used, unless something really bad happens in terms of safety. But in infectious disease, changes happen rapidly, epidemics come and go, and the FDA is not able to be involved in such a frequent basis, hence ACIP. But the idea is not to have the FDA approve a new therapy in a months-long process that involves review of gigabytes of data and hundreds of thousands of pages, literally. And then 2 weeks later, an ACIP committee member who has not even read the summary of the review, who says, nah, don't think so. That's not how ACIP is supposed to work. I was listening to Levi. He sounds very impressive. I've been in academia from 2006. I have a PhD in operations research from Cornell University. This is a discipline that is focused on trying to use data and models that inform complex decisions that involve risk-benefit trade-offs, using a lot of statistics, a lot of artificial intelligence, a lot of machine learning, a lot of different methodologies. And as he talks, I cannot think about that red bump on just like a noise, and no table 1, no patient population. And then he says, the main role that I will try to help with is to communicate to patients and medical professionals what is the best knowledge that we have. Levi is going to communicate to medical professionals about the best knowledge. And then Malone jumps in with more praise. First, I want to address the issue of the modest Dr. Levi. What he didn't mention is that he's bloody brilliant. He's a full professor at MIT in data science, data evaluation. That's no small achievement. Furthermore, he was quite brave and bold throughout the coronavirus crisis. In speaking his truth, he has revealed himself to be an independent thinker and not swayed by proven narratives or conventional thought. I think that the nation is really blessed of having such a mind with these capabilities serving in this way. I don't know that there has been this level of capability in data analysis before, he says. Really? What about the whole scientific community? And Levi says, I'm not sure we have been thinking deeply. And to that I say, Azochen Vei.